Hey guys, welcome to your online PowerPoint for the forearm, wrist, hand, and fingers. Because this PowerPoint is relatively long, we will separate the fingers into their own online lecture. So to start with, let's discuss the forearm anatomy. I think we kind of talked about this when we talked about the elbow, but just in case we didn't, let's go ahead and start a little bit of a review. On the medial aspect of the forearm, you have the ulna. Of course, this is if the patient is in an anatomical position, and so this is the medial side. And then on the lateral side of the patient, you have the radius. What we tend to see most often is that the ulna extends proximally further than the radius, and then the radius extends distally further than the ulna. And that's for two reasons. The first reason, number one reason, is so that the ulna can articulate with the distal portion of the humerus proximally, and then distally the radius gets to articulate with the scaphoid bone of the wrist. And so for those reasons, that's why we have different extension lengths in the two bones. What's awesome about the slide really is this anatomical structure right here known as the interosseous membrane. The interosseous membrane is really known for kind of creating an articulation between the mid shafts of the bone, right? These two portions of the bone. And this becomes important specifically when we pronate and supinate. When we look at pronation and supination, if we didn't have this interosseous membrane intact, then we would just freely be able to supinate probably too much and pronate too much. In other words, we just basically the radius and ulna would have no restraint over one another. Distally, what we see on most individuals are the styloid processes, or which are those two structures right here. And the styloid processes are prominent structures, specifically on the ulna. So when we turn our wrist into pronation, we'll see a small bony prominence, which will be the ulnar styloid process. And then on the lateral side, we do have the radial styloid, but it's just not as prominent as is the ulnar styloid. When we look at wrist muscles, or muscles that really control the forearm, the wrist, and the fingers, we kind of already talked about this in the elbow. I alluded to two muscle groups. So right now what we're looking at is really the medial aspect of the arm, and specifically the medial epicondyle. So what we see here are the muscles of the flexor pronator group. And so we can see that these muscles extend all the way down into the hands and the fingers, and they really control the rate at which we flex the wrist, the rate at which we flex our fingers, and then the rate at which we pronate the wrist. And so these muscles are pretty small in nature. They look large, but when you separate them out into individual muscle groups, they're relatively small. Again, controlling massive motion into flexion of the fingers, wrist, and pronation as well. I'm going to move back a slide. We'll again see that there is a flexor pollicis longus, which is responsible for flexing the thumb as well. What we'll look at is the extensor supinator group. The extensor supinator group, as I alluded to in the elbow, attaches onto the lateral epicondyle. And so it includes the extensors of the forearm, the extensors of the wrist and fingers, and then obviously the supinators as well. And then most intimately is this pollicis or the thumb. And so you'll see three pollicis muscles, and those muscles are responsible only for controlling motion at the actual thumb itself. So that's the abductor, extensor, pollicis brevis, and longus. As the names imply, they're going to abduct the thumb and then also assist in thumb extension. If moving back to that extensor supinator group, major motions within the extensor supinator group include wrist extension, finger extension, and then also supination of the forearm. As we move into pathologies, kind of like within the forearm, FOOSH is going to be a common mechanism of injuries for most of the pathologies that we'll discuss. And so we're going to start with forearm pathologies first. And so the first pathology is probably the most catastrophic pathology that can occur within the forearm, and that's a forearm fracture. And so it's most common in youth, and it's most often due to falls, specifically a FOOSH kind of fall will cause a fracturing of the actual radius and ulna, and it's usually mid shaft, so right where those bones are changing its shape. you'll see a through and through fracture between the radius and the ulna, but it can also occur as a result of direct blows. And most often we see this in our MMA, where a guy may have his hand or arm in an extended position, and if the person standing on top kicks that arm, then you get a fracture. You can also see that in soccer as well, if a soccer athlete's trying to get up off the ground and a slide tackle happens. So it can either be a direct blow or it can be due to falls. They most often, what we would say is that the radius and the ulna generally fracture individually. So it's rare that you have like a combined radial ulnar fracture. Although it is possible, usually one bone gives way, and that painful mechanism causes the patient to splint itself enough to protect the other bone from fracturing. So the signs and symptoms with any fracture really are the audible pop and crack. And then the biggest really differential is the amount of pain that the patient will be in. Most often what we have to really be concerned with is whether or not that patient is going to go into shock because they're in so much pain. And then associated with fractures that are not compound is lots of swelling, and then obviously disability. Other things that could be present potentially if there is a lack of a compound fracture is crepitus. Remember, I described crepitus as like taking your fingers on a chalkboard and then really scraping down, right? It's that creakiness that you get when two bones or pieces of bones are fractured and you kind of move them and you get that creaking sound. So what do you do for them? You splint, and there's a rule to splinting. In terms of splinting, if you have a bone that is injured, you want to splint the joint above and below it. So you're going to splint the joint above and below. And then if you have a joint that is injured, you want to splint the bone above and below it. So you always want to make sure that you have two anatomical structures in the actual splint to provide enough support. Again, rule of thumb, if it's the bone that's injured, splint the joint above and below. And if it's a joint that is injured, so like a knee sprain, for example, you'd splint the bone above and below that joint to ensure security. The next pathology that we're going to talk about is a Colles fracture. These are most commonly seen in Fuchs pathology. So the wrist is extended, the elbow is extended, the shoulder is in a little bit of abduction and flexion. And so you get that Fuchs, right, mechanism. And then that force travels up the radius and then stops right at that distal radial ulnar junction. And so what you get most often is a fractured radius, as you can see here, and the patient is going to present with what's called a dinner fork deformity. And so we can imagine, like, if we're eating dinner, right, we usually eat with the fork right side up. When we set our fork down on a table and we set it upside down, it presents like the teeth are here on the fork. I'm drawing this out for you, and then you have the fork here. So this is the dinner fork deformity that you most often see with a distal radial fracture or a dinner fork deformity. And if it's a compound fracture, there will be massive amounts of bleeding because of the radial artery that runs through there. So we want to control the bleeding and reduce the amount of swelling. But most often with a Colles fracture is the dinner fork deformity. So what do we do for these individuals? Well, this is injury to a bone. So we are going to splint the joint, which would be the wrist and the elbow, to ensure that the radius cannot move. And then we'll refer for x-ray. And most often that patient gets casted, and they're in a cast for approximately 6 to 8 weeks or until that bone actually heals itself. The next, so this is an example of what a dinner fork deformity would look like, right? We could imagine that this is the actual handle of the fork, and then these are the teeth of the fork. And this is an actual student who I believe went snowboarding and had a Fuchs mechanism, and then there was his fracture. So you can see how the radius has dropped down. And so we're going to splint on the palmar aspect of the wrist, making sure to include all of the fingers, and then we would go all the way up to the elbow in this instance to make sure that in fact our patient is truly protected as they're moving in the ambulance. So in this x-ray we can kind of see the through and through fracture here of the radius, and we can see how the carpal bones of the wrist really drive the radius palmarly, and so that's what creates the dinner fork deformity. As we move out of pathologies to the forearm, we are moving into pathologies of the wrist, and so it becomes important to kind of just briefly discuss the anatomy. As we all know, our digits are counted by starting with our our thumb, so that thumb would represent 1, index finger would be number 2, middle finger would be number 3, your ring finger would be number 4, and last but definitely not least, your pinky finger would be number 5. Each of the 4 actual digits, so we're referring to these 4 right here, have a proximal, middle, and distal phalanx, and then in between those phalanx we have joints, if that makes sense. And then we have our what are called metacarpals, and then last but definitely not least our carpal bones. And so all of these bones work together to create intricate hand movement that is so distinct and unique that it's really what separates us from other mammals. So as we move forward and we really begin to look at both finger and wrist injuries, I just wanted to give you guys an example of how many ligamentous structures really attached to just one finger, right? We can imagine that if we have injury to any of these ligamentous structures, the finger is such a small, tiny anatomical structure, and with that, lots of swelling in the joint would create or wreak lots of havoc. So we'll talk about the fingers in just a little. Let's go ahead and take a look at the intricacy of the small little muscles that kind of help move or provide fine motor movement. And so we have 2 groups of muscles that are highlighted in this particular PowerPoint. The first group is called the thenar muscle group, and I kind of think of thenar, thumb. These are the muscles that are going to be responsible for actually moving just the thumb. And we kind of talked about these with the flexor pronator group, but we have the adductor, adductor pollicis, the flexor pollicis brevis, the abductor pollicis, and the opponens pollicis. Now, I'm sure you guys know these 3 movements of the thumb, but the one differential for us that sets us apart from other mammals is the ability to opponens. So the to oppose means to be able to touch each of your fingers with your thumb. So to be able to do that is such a unique trait. And then on the opposite side of the thenar muscles, we have the hypothenar muscles, which control movement of the indicis or the pinky muscle. Otherwise, flexion, extension of the other 3 digits really are driven by either the extensor supinator or the flexor pronator muscle groups. So we're getting ready to look at the carpal bones, but I think like in anatomy, we always learn these kind of as like distinct rows of bones that kind of sit perfectly on top of one another. And so this image is really just to illustrate how these bones really truly look when you take kind of like a cross section of the wrist. They're really not the perfect row that we envision them to be, and that's kind of how the wrist is able to go into so many different motions. So it's a flexion, extension, there's supination, and pronation, which are rotary movements. And then we also have radial and ulnar deviation. So the reason we're able to do that is because of this unique design of the carpals and their relationship to the metacarpals of the fingers. So let's continue on with our injuries. We're going to continue on into distinct and specific injuries of the wrist. And the first and most common injury to the wrist are wrist sprains. And wrist sprains are common. The mechanism of injury or the etiology most often is either falling onto a hyperextended wrist or a hyperflexed wrist. Either way, if you have a hyperextended wrist, then most often you stretch or you end up compromising the flexor pronator group. And if you have a violent flexion injury, then most often you stretch out the extensor supinator group. So opposite motions lead to opposite muscle groups being injured. What we see with the sign and symptom is really just pain in the wrist, and then inability to kind of move throughout the range of motion in a specific motion depending on the mechanism of injury. With all wrist sprains, however, we're going to refer for an x-ray because the secondary concomitant injury to a wrist sprain most often is some type of fracturing. So we want to refer for an x-ray to make sure there isn't any fracture. If there's no fracture, then we rise that patient, splint them, give them some pain meds. Most often it's Tylenol, nothing too extreme. And then once they're pain-free, we begin strengthening and we'll tape. So for those of you taking Kin 2 ADL, you know that we can tape to limit either wrist flexion or extension based on the mechanism of injury. The next pathology we're going to talk about is a tendonitis. So it's caused most often by like repetitive pulling or tugging motions, because the wrist is being overused. And so it's an overuse injury. So we would treat a tendonitis similarly to a strain, in that the patient's going to complain of pain with that active contraction and then that passive stretch. So active contraction and passive stretch is what's going to cause pain, and that'll kind of tell you the muscle group that's injured, which would be associated obviously with the tendon, right? That would be compromised. So what do we do for these individuals? We treat them similarly to tenosynovitis. Remember that? And the treatment for tenosynovitis was what? It was rest. It was work on range of motion. It was to reduce